You're listening to Astonishing Healthcare, the podcast hosted by Judi Health, focusing on the biggest issues affecting healthcare consumers, benefits plan sponsors, and health plans. We're covering how things truly work or don't in the U.S. healthcare system and pharmaceutical supply chain, and we're doing it in an astonishingly efficient way.
Hello, and thank you for joining us for another episode of the Astonishing Healthcare Podcast. Today, I'm excited to have Michael Kleinrock from IQVIA back in the studio with me, almost exactly a year after episode 71, when we covered your 2025 Use of Medicines report. So here we are, Michael, talking about your latest U.S. Medicine Use Trends report for 2026. We'll be talking about the forces shaping drug spending and patient access, forces changing how people access the report, as the case may be, because that's even a little different, GLP-1 growth, the widening gap between list and net prices, policy-driven distortions. There's a ton packed into this one, I think, if it goes the way we expect it to. But, with scripted, unscripted stuff, you never know which twists and turns these conversations will take. Michael, thanks for joining me again in the studio.
Yeah, thanks for having me. And yeah, this should be fun. It was fun last year, and a lot that we had uncertainties about then we're clearer on, and there's new ones this year. So let's get to it.
Before we get into it, a little bit of background in case anybody hasn't heard you before, doesn't know about you, your team at IQVIA, what you do there. Give us a little quick.
Sure. The IQVIA Institute is a research-based part of IQVIA. IQVIA is a very large company that serves the life sciences sector globally. We operate in over 100 countries and 90,000 employees. We have thousands of colleagues running clinical trials as outsourced resource for sponsors. We have colleagues who are essentially outsourced sales reps for drug companies, and we have thousands of my colleagues that I've worked here 27 years now. So thousands of them who do data and analytics and services for governments, payers, providers, and pharmaceutical companies to better understand the use and spending on medicines in all of its attributes. And so whether that is the volume of medicine shipped, how it's being dispensed, whether prescriptions are being used or abandoned, what the list prices of them are, how those are translating into out-of-pocket costs, again, in over 100 countries with varying pieces of data available. And my team's work focuses on all of that. It's hard to focus on everything, but we have a number of reports, particularly our global use of medicines and our U.S. use of medicines, that really profile the U.S. in detail. In that U.S. report, a little bit less detail in the global, but the U.S. report is something we've been doing every year since we founded the Institute in 2011. And we made that without external funding and as a public service. And as you said, more recently this year, we have changed the way you access those reports. Previously, they were available free to download. In the new model, there is a charge for that material. There has been an evolving dynamic we can always talk about in terms of how AI is changing the way creators and content owners disseminate information. And the charge is in some way a way to protect that information from use by unintended audiences.
It's incredible, the unintended consequences of AI's rapid expansion and immeasurable use cases.
Certainly is an interesting part of it, but it doesn't help us yet solve the problem of a patient figuring out how to use their medicine or how to afford it. Those are still human interactions sometimes.
So to get right into it now a little bit, you and the team at IQVIA have really been able to refine your measurement approach, and you're comparing national drug distribution data with projected sales data and adjusting for gaps. Tell us a little bit about the exercise and how your approach has evolved.
Historically, we've been leveraging IQVIA's audited sales data, drug distribution data, to understand the spending on medicine in the market. What we've been realizing and adjusting for is that there are increasingly specific types of medicines and specific destinations of those medicines, which are not always well tracked in an audit. So if an audit is tracking wholesaler shipments and a drug like a cell or a gene therapy is not shipped through a wholesaler, that creates a gap as you described it. Similarly, there are a number of specialty companies who find that distribution of their medicines is more advantageous commercially to them if no one knows the exact nature of their business, other than perhaps a publicly traded company filing once a quarter. So those blind spots or gaps are a challenge for most of my peers in this space. And what we did in this latest report is we've put together our available resources in a novel way to essentially better estimate those gaps. And so we have a new and improved view of the market in its scale. As a guide, we are measuring the overall U.S. market at $606 billion in net revenue for industry. 84% of that is directly coming from SEC filings from those companies, either public companies or private companies who make an annual report that we can get to their product level sales. The remaining portion of that is estimated based on the patterns we see in gross to net for those that we can observe. And parts of the gross analysis before the discounts and rebates are estimated in a similar, suitably complex way. Now, the key element is that 606 is the net revenue the industry is receiving after all of the discounts and rebates and coupons and other things that they are conceding to every stakeholder, either from a regulatory mandated basis, such as a Medicaid rebate or a 340B, or through commercially negotiated discounts and rebates, or through coupons and patient assistance that they provide to patients. So that's the net afterwards, which is a really useful measure of what's going on. We also in the report measured the payer responsibility in an aggregate sense so that we can understand how much payers are responsible for and how much patients are responsible for. And then for fun, we also used list prices, which are a fiction for most of us. No one pays that, except if you have a high deductible plan or you are paying cash, sometimes your copay or your responsibility at the pharmacy is going to be linked to that. So we really wanted to put all of those options. That way there's a way to understand and analyze different levels of the market, different negotiated positions between stakeholders.
So talk to me a little bit about the numbers and what you saw year over year. Basically, you described gross to net bubble, where the list prices are. Like, what was the delta? What were we looking at year over year growth? If people are saying, oh, wow, spend on pharmaceuticals is up X% year over year. Any detail around the number to provide some context to it would be great to hear.
Sure. So $606 billion is the spend in 2025. That's up 10.6% over the prior year. By the way, 2024 was up 14.4% over the prior year. So we had two double-digit years, which is a really big contrast to what I think the expectation is with all of the discussions of drug pricing and policy and the Inflation Reduction Act and tariffs and executive orders, that surely this number is much lower. But in reality, this number is very high, 10.6% growth. And that is, it's only 9.6 if we take out the GLP-1s and COVID, which are outliers over the last 5 years. COVID had a couple of years at high 20s or 30 billion a year for those vaccines and therapeutics. It's been down much more recently. But the GLP-1s, so the obesity and diabetes GLP-1s, have had significant growth over the past few years. And generally, the number one question I'm asked by people as well is all the growth GLP-1s. And the reality is it's only 9.6% without that. So it's only a percentage point of the current growth. It was a little bit in 2024, a little bit more than that. But what we're seeing is even though there's this sort of generational flood of patients into these therapies, and it is unusual, it is a very high uptake, despite the fact that many plans are not covering them with a typical level of coverage for newer medicines. So patients, a lot of them are paying direct. And so what's been happening is that there have been price reductions, discounts, there's the direct sales from the manufacturers. And so overall, GLP-1 growth on a net basis is obviously a little bit lower. The result is this really strong contribution for the couple of companies that are involved there. And that's a central story to every conversation we seem to have. But that's not all of it, because the vast majority of it, the other 9.6% of growth, is spread across a whole range of products, dozens of them that are in a number of therapy areas: oncology, immunology, neurology. There are a whole range of areas where that growth is continuing, and they're midlife products. They're not launched in the last couple of years. They're a little bit older. They're not yet off patent, and they are significantly growing. There's 28 drugs with more than $500 million of growth last year. $29.5 billion of the $58 billion we had in total growth was coming from those 28 drugs. And that's excluding the GLP-1s. It's a significant widespread group of medicines that are, I guess, I think of it in the sense that they're growing that much, they must be doing something right from a multiple stakeholder perspective, because certainly not just the patients and providers and payers have to be satisfied with those medicines, or they wouldn't be getting that kind of support.
Can you talk a little bit about the spread? I mean, there is a large spread between WAC-based wholesale acquisition cost, right? Lots of acronyms in drug pricing and healthcare, and net revenue across the industry. And I think our more sophisticated listeners understand the details here a little bit better, but list price still matters. I think when people say nobody really pays list price, what's missing from that argument? Why does list price still carry so much weight in a market that claims to operate on net economics?
Yeah. So, I mean, we're talking about is 1.363 trillion, with a T, is the list price sales in the US market last year. So 606 to 1.36, 1.4 trillion, right? It's a very large number. It's about $670 billion is the spread. It's important that when we say nobody pays it, it's because those numbers are a fiction. In some sense, the list price sales doesn't ever happen. The list price may be a component of fee-based structures or percentage-based markup that different stakeholders take. But for example, example, from a list price, a wholesaler will probably buy at a significant discount from the list price. So the wholesaler discounts are a significant chunk. Historically, IQVIA has measured things at wholesaler prices. It's not a number that I put in the report this year, but it is a big chunk of that. And then what happens in terms of why we care about list price is that if you're in a deductible, depending on how your plan is designed, that prescription drugs cost, sometimes they'll be using list price as the allowed amount at the pharmacy. And so you're in your deductible or your coinsurance phase, that will also be tagged to that price. It's not always a list price. Sometimes it's tagged to an allowed amount, which is negotiated, but it's generally pegged to that in some way. So the structure of these benefit designs means that you're thinking about these costs as a consumer in that way. The spread also just tells us how the system works. While I don't specifically break down the spread in terms of how much is discounts to the wholesalers and how much is discounts to hospitals and how much is rebates specifically to PBMs, recognize that those rebates that PBMs receive on some drugs are part of the plan design for all of the covered lives in that plan. And those rebates are what essentially keep the plan balanced. And so large rebates on some products help cross-subsidize other products and other spend and keep premiums from rising. That's a really important marker for our conversation, because if we lower reimbursement prices the way IRA price negotiation does, it doesn't necessarily lower the net price. It lowers the reimbursement price and may remove some of the rebates from the conversation. If the rebates are missing, the insulation from premium rise is also missing. So there's a number of conversations where this waterfall, this crosswalk between the gross and net really starts to matter for different stakeholders. And it's frankly pretty arcane stuff, but it's central to how the system works. And it's not necessarily well reflected in the policy discussions that are revolving around it.
One of the more striking examples I think we talked about, you have in the report, insulin and inhalers. Is that right? Expand upon that. And then are there any other call outs from this year's report that you'd want to touch on for a minute?
Yeah. So, I think one of the more interesting dynamics that's happened in the last couple of years, and it certainly happened to insulins and inhalers, and it's a situation where the list prices of those medicines were dropped. And one would think that immediately means people save money. But what's interestingly happened, we've observed in the analysis, is that the net revenue the companies received actually went up for those medicines. And there's reasons. One of those is that in Medicaid, some of these medicines had historic price increases above inflation so much that their Medicaid price was essentially a penny. It had reached what is called the AMP cap, or the average manufacturer price cap, which was capped at 100% until January 1st, 2024, when the American Rescue Plan Act, the ARPA Act, triggered the removal of the AMP cap. With that AMP cap removed, if something would have a CPI penalty-driven rebate that was greater than 100%, there would have been this figurative tying a $20 bill or a $100 bill around a vial of insulin that would have been going on. It's descriptive. I'm not so sure it's strictly accurate how that works, but that's the concept. And so the list price cut has a significant impact, because it means that the price now dropping below the launch price means that it's now no longer subject to those CPI penalties. And now it's only subject to a best price and statutory rebate, which again, this is arcane stuff, but it's 23%. So for anyone at home doing in black and white wants to take what is the new price, for argument's sake, say $30, and take 23.1% off, you're going to find that that's more than a penny. The old AMP cap price exceeding 100% rebate it was always sort of penny pricing. They called it. It was 1 penny. So imagine there's a penny versus $23 or something like that. That's resulted in state Medicaid budgets actually absorbing cost for these medicines that they previously were not absorbing. And that creates pressure points in those programs, which is an interesting challenge for them when you cross that with the funding changes that have happened in last summer's budget bill that have Medicaid cuts that extend for the next foreseeable period. So where we're looking at these dynamics, you can find some breadcrumbs for some odd outcomes. And that's kind of what we're looking at with that insulin and inhaler example. And there's others where, say, for example, a company was subject to sort of an economic pattern where the patients who are typically getting a drug are unable to afford it. There's a lot of charitable care, but now we have the Medicare out-of-pocket cap. And so those patients can now afford that medicine, and it can go through traditional Medicare insurance again. There are some companies who benefited from their drugs no longer being charitably given and instead being funded through the traditional plans. Now the plan is responsible for more. That's a Medicare thing. It's not necessarily a commercial PBM decision. If there are negotiations or there are price cuts and there are rebates which are no longer in the mix, the flexibility and the latitude PBMs have in terms of the breadth of their portfolio, the generosity of the benefit design for the money, these are actuarial questions that don't resolve themselves very easily.
That's for sure. Anytime the actuaries get involved, it's It's serious. Big themes, affordability and access. You mentioned out-of-pocket costs in the evolving world of direct consumer, Trump RX expanding, partnering with Cuban now. Super interesting dynamics going on there. I'm actually curious though, in your report, you talked about this last year with us a little bit. Did you observe anything related to prescription abandonment or other related data that would suggest, an impact from everything going on in the market on affordability and access at the counter for patients?
It's funny, for abandonment, we've been seeing this trend for a long time. More than anything, what I'd say is that there's two things that I can see in the data. One is that the volume trends in the market are continuing below a pre-pandemic level. So even though we're done with the pandemic and we're recovered, patient behavior has a number of milestones. You're sick and you know it. You turn up to the doctor or provider in some fashion. They prescribe you something and then you get to the pharmacy to decide if you can afford it. What we're seeing though is the economic effects and behavioral effects of them not approaching the provider in the first place. And so there's this sort of lower initial presentation, which then has this downstream effect. If I didn't go to the doctor 2 years ago, I wouldn't have got through the various diagnostics and scans and blood tests and prior authorizations and step therapies to get to a drug therapy, to get to a generic and then step through to a brand. There's a lag effect for branded prescriptions that drive higher costs. 93% of prescriptions cost less than $20. So the vast majority of people have an affordability situation, which is fine for the ones who fill those prescriptions. But for the ones who don't, they're missing to us. If they never made it to the doctor, we don't know they're there other than some sort of general view of how many people should be sick. What if we're just healthier? That could be great. I mean, everybody had oat bran muffins in the 80s and everybody's doing great and we're all going to the gym. Or there's a number of people who are stuck behind the burdens of life and are generating worsening health outcomes, which are significantly concerning. It's hard to tell the difference between those sometimes. And so what we're looking at is the tags or the breadcrumbs of those theories and try and figure out which is which. And so abandonment is always, it's like a straight social science maxim here, is that if you see a cost above $125, more than half of those people are going to walk away. And that to me is a really convenient number, by the way, because typically in a high deductible health plan, a primary care visit is about $125 list price. And half the people are not going to go because they know how much it costs. Obviously, an annual health check should be free and preventive care should be free, but a lot of people don't really know how the system works. And so they avoid care because they just aren't thinking about it, especially younger and healthier and working people and people with kids. Like our kids go because they're jumping out of trees, but the rest of us tend not to go to the doctor as often. All of that translates into missing prescription volume, missing use of the system. And is that an affordability problem? Probably. Secondly, there's then the issue of the people who do show up, who made it some of the way through and then still abandon or still are not persistent on therapy. We study that a lot in the report, and we find significant evidence that there are really access and affordability barriers for patients who have gotten far enough for their doctor to prescribe something, and then they still don't stick with it for a sustained period.
Interesting. Is that a benefit design issue, you think? Or what's driving that? Or what should the plan sponsor listening to this episode think about?
It's important to have context. So when we've talked about the GLP-1s, for example, there's a lot of talk that you'll regain the weight if you don't stay on therapy. And we had a chart in the report where we found that basically GLP-1s have at the end of a year, about 30% of people are still on therapy. And you think, oh, so 70% of that was a problem. Except that 30% is fairly typical across 4 other large chronic therapies. At the end of a year, 30% of people staying on therapy is roughly what happens normally. What we haven't quite figured out as a society, as a system, is what happened to the other 70%? Is that an affordability question? Is that a clinical question? Did it not work? Did it work and they're done? All these kinds of questions. You would expect with something that's a chronic maintenance condition, hypertension, cholesterol, the likelihood that you would be able to take something for a short period of time and be done and fixed is pretty low clinically. That's not how those things work. That's why we selected those classes in the analysis. The idea would be that those are expected to be maintenance therapies and that their patients are not there is a breadcrumb for all of us to be thinking about how to retain and have persistence on therapy, because some might say that's waste, right? Some might say that you started and you didn't finish. We didn't get anything for that. It's not waste that should be avoided. It's waste that we didn't finish the job.
And somebody who worries a lot might think, oh boy, costs might go up in the future because you came off and you should have stayed on.
Well, right. And so there's a risk that that patient's outcomes worsen because they're poorly managed, say in diabetes or in heart disease and so on. Certainly that's one of our questions, is that if adherence were better, if adherence and persistence were better, we'd actually use more medicine, spend more on them, and have better outcomes, all things being equal. But we don't. And so there's a question not about what an ideal situation is, but let's track the current and see how that's moving. That's what our report's trying to do every year, is really track the current trends and see what's going on. And we don't necessarily have an inflection in more abandonment, more affordability problems, but it's still here in pretty large numbers. Even for low cost prescriptions, you have 10% abandonment. It's not like there's only high cost drugs that are the problem. Patients are abandoning $20 prescriptions too.
All right, Michael, we got two more questions for you. First one, what's one other interesting insight or underappreciated thing you found in this year's report?
So one thing we found is that Medicare patients saved a bunch of money. So Medicare patients, because of the cap, the out-of-pocket cap, there's a group of patients who have spend that's above the annual cap and their costs went down. That's an important dynamic because they've stopped working, right? They're retired people usually. So their ability to absorb excess costs is more limited. The older folks in the audience sometimes say, I'm on a fixed income. Those patients saved something already, even before the 2026 implementation of price negotiation on the drugs that have started to be listed in that part of the policy. I think that's an important dynamic. The other sort of underappreciated dynamics is that when you're seeing costs go into the system from prescriber visit, we have stats here, 29% of new prescriptions are unfilled across payers. What is happening there in terms of those new prescriptions? We have obviously plans not covering certain medicines. We have ways patients navigate around that, either with a coupon program or with paying cash in some cases. We also found with the cap in Medicare, there's an interesting group of patients, almost 1 million of them in Medicare, who still had costs above the cap. And what is happening there is they're not using their Medicare. What's happening is that they're using cash to pay for things that are not covered by Medicare. Some of them are not covered by law, so you can't get obesity drugs, was the more common one for a few years. There's a slight policy change there, but most people aren't aware of it. But also things like erectile dysfunction that are not covered on Medicare. The patients are sort of, I'm a Medicare patient, but then I'm paying outside. By the way, that's not in the report, but it's a definite true area, is that commercial patients have a similar dynamic. Their insurance covers some things, it doesn't cover others. They go outside. Some of it is because of the drugs they need. Some of it is because a store-based or an independent-based coupon program might offer them a better deal on a generic or a branded generic or something. And so they do that. Insurance not being the only way patients pay is definitely one of those underappreciated dynamics. What's probably also important to say is growth is not all obesity. We definitely have some looming savings coming in terms of patent expiries in the next few years. Obviously, the price negotiation is going to start affecting more drugs each year. That's an effect. And overall, the outlook, this double-digit growth is going to slow, we think. We think it slows to about 4.5% to 7.5%, that sort of range through 2030, which doesn't seem like a big reduction. I've been doing this analysis when growth in the US market was 1%, 2%. Mid to high single-digit growth is still a big number, especially considering our population growth and economic growth and so on. Still robust value being attributed to medicines and use of those medicines and treatments across a whole range of diseases that we are seeing, and weird outlier upside potentially in there. We have more GLP-1 usage. If we have drugs for MASH, is this sort of liver function metabolic disease. If we have Alzheimer's therapies that are coming through the pipeline, if they are somehow more effective, if we have range of, again, the large number of drugs that I mentioned that are growing pretty strongly, those all contribute, and they contribute for those individuals with better health outcomes, hopefully. And that's a big dynamic. It creates some interesting pressures for all the stakeholders. It creates a pressure for how to keep a premium at the right level for plan design, how companies who are covering their employees, how they're going to offer a benefit that their employees are satisfied with. That squeeze in this economy is a tricky dynamic that we observe just as well as the rest of you. And I think that's what I'd see overall, is we have this significant amount of innovation, really low average cost for most things. Those high cost outliers and that sort of pushing cost to patient for a very high cost drug is sort of an interesting challenge. And there's pretty strong demand, but there's this mixed story. And probably what I didn't even cover at all is just sort of that volume use sort of below expectations has some mixed stories. We have really strong immunology and oncology growth. Vaccines, notably stronger than we would have thought.
As you were speaking there, it's wild, the transition in the market. And then I was thinking back to something Jim Winkler said, talking about their survey and how everybody got used to, oh, it's unsustainable. The growth in costs is unsustainable. But after a decade or so of rising costs by double digits, we're like, wow, now here we are talking about up another 10 and change percent year over year on a huge number. Going down, of course, some of that is a law of it's a larger number. It's still getting bigger, but it's a smaller percentage point. It does seem like there's got to be a breaking point, but just keeps going up every year because of the dynamics. It's crazy.
Yeah, I mean, if we think about some of these therapy areas, so immunology in the last couple of years outlook, I had an expectation that big patent expiries and biosimilars for Humira and Stelara would have collectively, those two were the leading drugs in immunology. They were accounting for almost half of the spend in the whole market. And you think, okay, those biosimilars, we should save a bunch. In reality, the system collectively, everyone decided, you know what, the next generation of therapies across a range of immunology conditions are something that's worth spending on. And we've had some savings from biosimilars, but what we've also had is a shift to the other novel therapies in psoriasis and Crohn's and ulcerative colitis and severe asthma and a number of other areas. And so when you think about the sort of, are we going to sit pat and capture the savings, or are we going to keep moving to the next thing because unmet need is a significant issue? It seems like we're seeing the unmet need doing better than the capture of the savings. And the same thing happens in oncology, where we see continued move to newer therapies, and not just newer therapies, but those newer therapies have longer survival and longer treatment duration. So the patients get to stay on therapy longer and have a regimen that includes that newer medicine, but lasts them longer and they live, which again, sounds great. Let's do that. The trade-off between capturing savings and having something better seems to be tilting towards innovation, tilting towards the something better across a whole range of therapies. And that's great news for patients with those conditions. I mean, think about the migraine patients who have a number of new therapies in the past few years, where migraine was something that you would put a heating pad on your head and suffer with. What medicines did work for you. And now there's a number of new options, new mental health treatments, some new mechanisms for the first time in decades. There's just so many pockets of innovation that we're seeing that I could be excited about them from reading the abstracts, but it's not just that. It's that the market is rewarding them financially, which suggests to me that they have both that clinical excitement and something that works for people. That's what we're seeing here is the really interesting dynamic. And I think it's hard to say no to things that work for people. I think there's a temptation to consider that insurance and plans are here to say no. I don't think that's how it works. I think they're here to get the right value for their sponsors, but that historically we have found ways to constrain spend that seems like the medicines are overcoming that.
All right. Last question, Michael. Keep your compliance hat on for me. And you've seen a lot over the years, and over the last year, you've seen a lot because all the data you guys have access to. What was the most astonishing observation in this year's study? Send us off with a good story.
I think the most astonishing part of this was how much the patient volumes in GLP-1s increased. It basically doubled during the year of 2025. For all of the media reporting and enthusiasm, I didn't think it could keep accelerating in the same way that it was doing in the past 2 or 3 years. This started ramping up with social media influence and celebrity hype that has gone from strength to strength. And there's better clinical data coming out all the time from each of the companies. Looking forward, that one says to me, what are we going to see? Well, in our R&D trends report back in March, we put out there's almost 200 obesity drugs in development in some way. And so success rates being what they are, I don't think we'll get 200, but there could be a number of options. And we've seen some more. So we've seen oral options. We've seen different sort of maintenance options and different treatments. So there's choice. Choice leads to competition. Competition leads to lower prices. Potentially, widespread use of the lower prices in terms of consumer-facing things, direct to consumer being this sort of new channel, whether it's the TrumpRx.gov or whether it's companies having their own direct shipment options for these therapies. Those are not the system we've had. Those do not fit into the orthodox pharmacy, PBM, medical insurer mix. They fit into something else. So that's probably the most dramatic salvo. Volley in the way the market's evolving is sort of one of the more exciting things that's going on is not involving every one of the traditional stakeholders. The big number, the double digit for another year, and the real widespread across multiple therapies benefits that are accruing across the market is really, that's what I'm taking away.
If somebody wants to learn more, send us off with the website, where to find you, where to find more about the report.
Okay, so you can go to IQVIAinstitute.org. So that's IQVIA Institute, all one word, .org. and look forward to you turning up there. And we should be having a webinar with some panelists discussing the report as well, coming in the next couple of weeks ourselves. So if you want a repeat of this, we definitely look forward to sending people over to that as well.
Michael, thanks again for joining us. Have a great rest of your day.
Thank you very much.
Thank you for listening to Astonishing Healthcare. Head over to Judi.health and visit the Insights section for show notes and other relevant content. If you like this episode, be sure to subscribe so you don't miss the next one. And definitely share the link to this show with your network. Have a great rest of your day.